Welcome. It's such a pleasure to see so many people here interested in people living with congenital hyperinsulinism. My name is Julie Raskin, and I am the parent of a grown-up child born with congenital hyperinsulinism, and also the CEO of Congenital Hyperinsulinism International. It was almost 30 years ago today. It was a late spring day, not so different from today. The sun was shining, peonies were in bloom, and so was I, ready to give birth to the son who would complete our family. But just a few days later, my husband and I were by the side of our newborn son, Ben, but not at home, in a neonatal intensive care unit, where dextrose at a very high rate was coursing through his veins to keep his brain safe from further injury. Until discovered, Ben had quietly suffered from severe hypoglycemia caused by a disease called congenital hyperinsulinism. And today, in this brief 30 minutes, we're going to learn about problems and solutions on the very bumpy road to improving life for people born with congenital hyperinsulinism. We will learn about how international cooperation between clinicians, researchers, and the community of people affected by the disease are united in a quest to increase care for people with hyperinsulinism. We'll hear from Henrik Christesen from Odense University Hospital, and from Nino Kheladze from the country of Georgia, Tbilisi, about challenges there. And we'll learn about the Global Access Survey from Lauren Lopez from Congenital Hyperinsulinism International, and the Open Hyperinsulinism Genes Initiative from Sarah Flanagan from the University of Exeter. First, I'll just tell you very briefly a little bit about Congenital Hyperinsulinism International, how I, together with many, many parents from around the world, joined together to create a global community, a movement to improve the lives of people born with congenital hyperinsulinism, working in 3 areas: in support, in awareness, and in research. And we help patients around the world receive life-saving medications, treatment, genetic reports, and medical supplies. We're not always successful. We're often not, but we keep working to improve and increase access. That is our life's goal. And to serve as the global source of support for families who can come and share with us what their problems are, what their needs are, and their triumphs as well. And we designate centers as centers of excellence so that families know where to bring their children for the very best possible care, where there's multidisciplinary expertise, so that children have the very best chance to start out life and continue life with treatment, with care, with a personalized approach that is evidence-based, so that they can grow and develop to their very greatest potential. And these centers are in Germany, at Charité, and the Collaborative Alliance on Congenital Hyperinsulinism, and in Philadelphia at the Children's Hospital of Philadelphia, and at Great Ormond Street in London, and the Northern Congenital Hyperinsulinism Service in Manchester, and Odense University Hospital here in Denmark, and in Fort Worth, Texas, at the Cook Children's Medical Center. We also work on awareness, because raising awareness of hyperinsulinism, it saves lives and it prevents brain damage. So we have posters, we have information in 25 different languages so that people can learn how to prevent prolonged hypoglycemia, and then the basics of how to care for patients and facts about hyperinsulinism. We also create awareness through making films, and now we're making a professional film that is called Turning Hours into a Lifetime, so that we can share with a much bigger audience outside of the bubble of affected families and professionals, so that more and more people learn about hyperinsulinism. And along the road, we are starting this year, very next month, with a Global Hyper Awareness Day, and it will be on June 7th. And we are debuting our campaign, which is A Healthy Brain Depends on Normal Blood Glucose, and that glucose is truly a vital sign, and attention needs to be paid to it from the very beginning of life. So we're asking all of you to join with us in this campaign so that we can raise awareness, again, beyond our bubble into the mainstream of life. And we also have a mission to improve treatments and improve diagnostics. So we've created the Collaborative Research Network that brings together patient advocates with researchers and clinicians, with biotechs, academics, so that we can advocate and take on the very biggest challenges in treatment and in diagnosis. And we collect the experience of living with hyperinsulinism through our HI Global Registry project, which is global. And through our $1 Million Bike Ride project, we're able to give pilot grants to get research started, give researchers some money so that they can get going on the big ideas that eventually will be funded and will be developed into new treatments and, again, better diagnostics. And we also conduct qualitative research to bring the patient voice to the light. We also are working on a project in the European Union. It's a photodynamic therapy. We work with the researchers who are developing the treatment, but our focus is on raising awareness, developing patient-reported outcome measures, expanding our registry, and really bringing to light the issues that patients face so that we can come to our goal, which is to reduce brain damage from congenital hyperinsulinism. And now we're not actually going to have a discussion. We're going on to our next speaker. So let's see. So our next speaker is Henrik. Henrik, come up, and we can just go through each speaker to the next, and then at the end we'll have time for questions. Thank you very much.
So can we move on? Right. Thank you for inviting me. I'd like to tell about our center and our collaboration with the family organization. We have a multidisciplinary international center on congenital hyperinsulinism here in Denmark. And we had referral of more than 100 patients from other countries. At the time, especially from Ukraine and Sweden, but from many other countries. Being multidisciplinary means that it's a complex disease that needs to involve a lot of disciplines: genetics, pediatricians, dietitians, physiotherapy, and so on and so on. Pancreatic surgery, anesthesiology, and pathology at the end. With time, we made a lot of papers on this disease, and also a few PhDs, and that can only be done through international collaboration. And here you have examples of some of our collaborators. You see it's from many, many countries. And that also involves the clinical work because our research is close to the clinic. But having the big chance to collaborate with the family organization has improved the international collaboration for us a lot. Our partnership with the family organization started maybe more than 10 years ago, but one example here 9 years ago was that Julie emailed me about a patient from Georgia, and you will present shortly afterwards, in need for help. I said yes, and she was referred from Georgia to our institution and cured by surgery for a focal lesion. One good example, and many more to follow. We were involved from Denmark here in the Scientific Advisory Board and in the Collaborative Research Network with annual meetings, doing care guidelines, work streams, and now especially focusing on neonatal screening for hyperinsulinism to prevent brain damage. and being active in the global registry. Last year we were designated as one of the 8 centers Julie talked about, centers of excellence. And I think this has an impact. This is important for us to have a quality stamp from the International Family Organization. It means that other centers are more secure to send patients to us. We have more international collaborations, not only in patients, but also on research. It increases our funding possibilities, and recruitment of young researchers are also strengthened. And in hope, our hospital will not cut us economically because of this quality stamp. Here Friday, Saturday, we had a pre-conference here in Copenhagen with the patient organization, which was very fruitful, I think, and for the families and doctors participating and nurses, this was really a good focus, and I hope that there will be more pre-meetings at next conferences, and many more will attend, maybe from here in the audience. Thank you. Nino?
Oh, okay. Good afternoon. Thank you for giving me opportunity to share the voices of the Georgian patients. I live in Tbilisi, Georgia. I work in the biggest children's hospital in Georgia, where 1/3 of the beds are dedicated to the ICU. I've been pediatric endocrinologist for 13 years, and every time I get a call that a neonatal ICU has an infant with severe hypoglycemia, I feel terrified. I feel terrified because I think, what's next? What if it's congenital hyperinsulinism? What if it's not something that we can manage locally? So the story with me and congenital hyperinsulinism started in 2015 with this patient, Valery. I found him in the neurology unit. He was tested to have epilepsy since the age of 1 month, and he basically looks as terrified as I felt when I first realized that he definitely did not have epilepsy and had congenital hyperinsulinism. And this is 2015 when I came across to several problems. First, it was a need to increase awareness. I realized that only maybe a few people realized what was congenital hyperinsulinism. It was extremely hard to convince my colleagues, neurologists, that the child whose blood glucose is extremely low, insulin level should not be normal. It should not be measurable. Then I came across to the problem that I had no resource to treat this patient. I did not have any medication or any testing abilities. There was, of course, no clear guidance document in Georgian available that would manage this problem. Genetic testing, of course, not available locally. And if I had to refer this child to a specialized center, I didn't know of any center or did not have any communication. And of course, financial considerations are very hard. He's from a very poor family, and up to this date, he's 10-year-old. He has not bought even 1 box of Diagnostics himself, and I, with your help, try to somehow get him the medicines that he needs in everyday life. Next, there were 2 more patients. One, Nini, she has hyperammonemia, hyperinsulinism syndrome, and has also had ongoing seizures. And another one, David. And as soon as the parents realized that there was no treatment in Georgia, there was nothing. Even Diagnostics was extremely hard to forget. They moved, the whole family moved to France and asked for asylum with the reasons that they could not get the medical help at home. And then came Nene, the very famous patient, absolutely gorgeous little girl from a very nice and young Georgian family who was absolutely healthy otherwise, but had severe persistent hypoglycemia. We tried diazoxide. We got it from Valery. He gave borrowed it to us. We found some octreotide, but it was not also helping. We had no glucagon, and there were episodes when her blood glucose was unmeasurable, and the only local option we had to do the complete pancreatectomy. And the miracles do happen, actually, if you keep trying and if you don't give up. So basically, I have to admit, I Googled and found Julie. And I kept writing to her, and she was responding immediately. She helped me to connect with Exeter, and they were absolutely wonderful and did the testing very fast. And fortunately, I cried a lot when I got the testing result from Exeter that she had the type of mutations that could have been focal. And Julie also advised me at that time to write to Dr. Henrik. And by another miracle, he was able to get her. And by the age of month and a half, we somehow, but with a lot of hardship, managed to get her to Denmark. Well, there were a lot of bad things that happened on the way. She almost died because she had to go with the ICU doctor. She ended up to having a blood clot in her heart and so on. But finally, she got there. We were able to do the surgery, and she is cured now, and we'll see her in a little bit. But now in 2025, 3 patients currently are receiving diazoxide in Georgia, and there is no way that they are getting it themselves. One died, unfortunately. She also had a focal disease, but before we could get her do the surgery, she died of sepsis. 3 had transient form and now are not treated. 2 immigrated, as I told you, because of the non-availability of the treatment. 2 were cured due to surgery. 1 had Beckwith-Wiedemann syndrome, and they also immigrated. Still not enough awareness, I think. Essential medication still not available. But CGMs are now available, and we really use it quite well from the neonatal ICU. PET scans are available in the country, but they don't do neonates, of course. No new cases this year, but I don't think it's necessarily good. Maybe they just died unrecognized. This is what I kind of think most of the time. But for now, I know who I should ask for help. The help usually I get from outside. And some of the actions that I keep trying is I keep trying to write to the minister, asking for help, involved all the local rare disease associations, reaching out to all pharma companies and local pharmacies, maybe to supply diazoxide, use almost any platform locally, or we had an ESPE Caucasus school in Georgia recently to share the information to nearby countries and the other colleagues that may also encounter the same problems that I have, trying to be involved with the congenital hyperinsulinism activities, and we do have an ongoing study from Resolute. And I'm extremely grateful to all these people. I cannot say how much. And you can see on the picture the actual patients, and you see how Ulrike from Germany and the German group of patients are sending the medicine to my patients, and how the Oliver is writing recipes for these children so this medicine can be purchased in Germany and delivered to Georgia. And each of you helped me immediately as soon as I asked for help. And this is actually one of our congenital hyperinsulinism patient, Nini. Yes, she is not doing something safe, but at least she is active and she is trying to reach her goals. And I think that's the only option we have to not give up.
Hello, my name is Nino. I'm 9 years old. I study well and I have many hobbies. I love to dance, sing, draw, and swim. I was born in Tbilisi, Georgia. I had very low blood sugar. I was very sick and could not be cured in my country. I want to thank my doctor Nino, who helped connect my family with Mr. Henrik Christesen in Denmark. He performed a life-saving operation on me when I was only 1 month old. There are no resources in my country that could help me then and can help other babies even now. Thank you, dear Henrik and team, for saving my life. I'm sending you lots of love and gratitude. Tack.
Thank you.
Well, I'm not sure how I can follow that. Let me see. So, hi everyone, my name is Lauren Lopez and I am the Registry Director at Congenital Hyperinsulinism International. And I've worked there for about a year and a half now. And in that time, and from Nino's talk as well, you've heard about significant disparities that patients with hyperinsulinism face around the world. There are vast differences in access to diagnostics, medication, surgery, even expert clinicians that have the expertise and the knowledge to diagnose and manage the condition. So at Congenital Hyperinsulinism International, we are aiming to address these disparities by first assessing what gaps still exist in the community today. And to do this, we have launched a global access to HI care survey, where we aim to identify barriers to HI care across the world, collect valuable insights from the healthcare professionals that treat patients with hyperinsulinism to inform our advocacy and support strategies, and to highlight the gaps in access to medications, resources, and knowledge. This survey is available in both English and Spanish, and it is open to any clinician who has ever treated someone with hyperinsulinism. So this may include pediatric endocrinologists, metabolic disorder specialists, general pediatricians, and nurses, but of course, patients with hyperinsulinism grow up and become adults. So if there are any adult endocrinologists that also manage patients who have had hyperinsulinism, we encourage you to complete this survey to share your experiences as well. And it takes less than 20 minutes to complete. It's not very much time for a huge impact that you can have on the HI community. This survey was previously launched in 2018, and at that time we had over 80 respondents from 45 different countries around the world. And the data from this survey led to the addition of diazoxide to the World Health Organization's list of essential medicines, which I think really underscores the immense impact that you can have by completing this survey and sharing your experiences. The Global Access to HI Care survey has been updated this year to cover many more topics and to really get a sense of the true access issues that patients are facing around the world. So we're covering topics such as epidemiology, medication coverage, medications of diazoxide and octreotide, access to diagnostics and other services, clinical trial opportunities within different countries, and also any additional resources and supports that the physicians treating patients with hyperinsulinism may need. We really appreciate the time and effort that you put into completing these surveys as well. So we are offering a raffle to win one of 3 $100 gift cards for clinicians who complete this survey. The impact that you can have on HI care and advocacy is really important here. So we encourage every clinician who has ever treated someone with hyperinsulinism to complete this survey and also share the QR code with any colleagues who also treat patients with hyperinsulinism. Thank you very much.
Thanks very much. I'm Sarah Flanagan from the University of Exeter, working on genetics of hyperinsulinism. So a genetic diagnosis of congenital hyperinsulinism is absolutely critical for all individuals who are diagnosed with this disease. Not only does it inform on recurrence risk, but it can also guide clinical management. So, for example, if we find a variant in a gene which we know causes a syndromic form of hyperinsulinism, then we can recommend that the clinician monitors for the development of additional features in later life. Another example is seen in individuals with GLUD1 variants. These patients may have protein-sensitive hyperinsulinism, so may benefit from some dietary manipulation.
or if we found variants in genes such as HNF4 alpha or 1 alpha, we know that these children are at increased risk of developing diabetes in early adulthood, so we can recommend monitoring for diabetes as they enter adolescence. But perhaps the best recognized example, and what we've already heard about, is for the children who have drug-resistant forms of hyperinsulinism. Because if we're able to identify a potassium channel variant in these children, then we can predict whether or not they have diffuse disease, which may need a near-total pancreatectomy, or focal disease, which is curative by lesionectomy. So because of the importance of identifying the underlying genetic cause of hyperinsulinism, in 2018 we launched the Open Hyperinsulinism Genes Program, which is a partnership between Congenital Hyperinsulinism International, the Genomics Laboratory, which is an NHS laboratory in the UK, and my research team at the University of Exeter. And this program was really designed to ensure that there were no geography or economic barriers to genetic testing for this condition. So since its launch in 2018, we've provided free genetic testing to over 1,000 families diagnosed with congenital hyperinsulinism from 62 countries around the world. And you can see these patients come from all continents. And our process is that for all individuals, we'll provide rapid Sanger sequencing of the potassium channel genes, aiming to get a result out within 1 to 2 weeks. And then for those where there's persistent disease, if they don't have a potassium channel variant, we'll do targeted exome sequencing of 25 hyperinsulinism genes. And these are the results of the study so far. So, so far we've been able to provide 52% of families with a genetic diagnosis. You can see variants across multiple different types of genes. But the most common, as others see in their cohorts as well, are variants in ABCC8 and KCNJ11, which encode the potassium channels. And this is really important, as we've just heard, because that meant for 384 children, we were able to predict diffuse disease, and for 139, we were able to predict focal. And this is one example of the impact of this. So this is 14 of the children with focal disease are managed by Dr. Evgenia Globa in Ukraine. She sent her samples from her patients to us in Exeter, and then in collaboration with the team here in Denmark, those patients underwent PET-CT scan and curative lesionectomy. So as well as providing routine testing, we also provide opportunity for families to enroll in research studies. So every family receives a full diagnostic report, and then accompanying that report is a patient information sheet, which provides details of how those individuals can access the CHI Global Registry. Patients are also able to enroll in gene discovery studies, and this becomes really important for those 48% of individuals who are currently without a genetic diagnosis. So they can agree or consent to enter our genetic beta cell research bank, where we're trying to find novel genetic causes of the disease. And we've had some success recently, resulting in more families receiving genetic diagnoses. And these papers have also resulted in new knowledge of genetics, disease mechanisms, and improved clinical characterization of the condition. So that's my whistle-stop tour of the Open Hyperinsulinism Genes Project. I just really want to acknowledge Jane Houghton in Exeter, who runs the diagnostic service. But most importantly, many thanks to all the clinicians who are sending samples to Exeter. I really appreciate that it's a huge amount of work to get the samples there, and it's really appreciated, so many thanks.
Thank you to all the incredible speakers who are doing this fantastic work to improve the lives of people born with congenital hyperinsulinism. So we have a few minutes left, and if anybody has a question for any of our presenters today, or if anyone is doing some kind of work on congenital hyperinsulinism you want us to know about, please ask a question or share. We have just a few minutes. Yes.
Thank you all. That was a series of amazing talks. So I'm now working in the UK, but from Australia, and I've seen on your map there's, in terms of the DNA, you know, there's 2 samples from the USA and 4 samples from Australia, because those countries have labs that are doing these tests themselves. Is there a system for those results to be sent through to basically put all the information together so we can get a better picture on the rates of each of these causes?
Yes, yes. The answer is yes. So it's an excellent question, and you're absolutely right that in Australia you have your own laboratories and there's a lot of work being done there. Through the HI Global Registry, any individual with hyperinsulinism or their caregivers, usually their parents, can join. They can upload their genetic report and share that way. So anybody can, anywhere in the world. And then Dr. Flanagan also has all sorts of relationships with geneticists and clinicians around the world collecting this in other ways as well.
Hi, my name is Melanie Henrik. I'm from the University Hospital at Dritte Orden in Munich, and I have a question to the room, as I have so many experts in one room. I have a patient who was born with esophageal atresia, and I know there are a couple of studies published of children with esophageal atresia, he also had an aberrant cardiac defect, which was now treated, causing streeters. But after, I'm not sure if we only diagnosed it late, or after approximately 3 weeks, we found him having, it was a routine blood test where we found a hypoglycemia with elevated insulin levels. The rest of the growth panel was absolutely normal, so his growth hormone cortisol levels was all normal. He also reacts to Dioxit, and we've now put him on a part ketogenic diet because we noticed that he always has peaks. So he was fed with mother's milk. He had peaks. We tried, I don't know if it's called glucosade in Germany. It's cornstarch, and that also didn't help. Maltodextrin also didn't help because we always had high peaks up to 350, and if we increased the Dioxit amount, it just kept the base level going up, but we even had more peaks. We just then had no hypos anymore, and now we put him on a part ketogenic diet and have a good blood sugar. But the problem is that we haven't done genetic testing, so we did a whole exome sequencing, but we haven't found a gene, and maybe in the room somebody has a similar case.
Would you like to raise your hand if you have experience in this?
I'm coming in.
Okay. Do you want to respond now or connect? Okay.
Oh, I'm sorry.
I'm coming from Great Ormond Street Hospital, London. We have published at Hormone Research of Pediatrics like 6-7 years ago, post-surgical repair of esophageal atresia, they do develop postprandial hyperinsulinism. It is well known, very rare, well known. They don't respond to medications usually. Postprandial hyperinsulinism can be very challenging in children. Dietary intervention is promising. As soon as they enter oral diet, postprandial hyperinsulinism children are more stable. That's why we have been awarded as a novel insight from the Clinical Practice Award of Hormone Research of Pediatrics, because we did describe this in another condition, but it is well known. Now, regarding ketogen, they don't respond to medications. You should try the medications that we use for congenital HI. Not always, but definitely it should be used. And if there is response, mainly it is dietary intervention for the ketogenic diet, because there was a question also yesterday about this. We need to be a little bit careful. It has been reported in patients with congenital HI, not postprandial HI. Postprandial HI is completely different condition, has nothing to do with congenital HI. But with the ketogenic diet, we need to be a little bit careful. It has been used. There are some case reports published from Italy in GLUT1 that it has worked well, especially from the epilepsy point of view. But when we discussed a few years ago in a conference in Philadelphia, we need more strict protocols, assessment of this diet, and it is extremely difficult to follow, extremely challenging, affecting quality of life, and we want treatment plans that they will offer normal quality of life to our patients.
Okay. Thank you so much for coming and listening.